Oh, hi YouTube. Hi guys, Dr. Reeves with Neurology here. We're going to talk about dementia today. Once again, we're being assisted by the awesome camera girl and director, Alana, the blue-haired camera girl. And we're going to go with a discussion of what dementia is and some of the common dementias. We're not going to get into all the different treatments or lack thereof in some cases. So, definition of dementia: loss of previously held cognitive abilities. Not ability, but abilities. There has to be impairment in more than one area for us to really call it a dementia. Now, the important thing about dementia is to understand that dementia is a description. It is sort of like saying somebody has shoulder pain. It's a who and a what and a where, and it says the shoulder isn't functioning normally. But it doesn't say anything about why. It doesn't say that, there's bursitis or a broken bone or a pinched nerve or whatever. So when we say, Grandpa Franklin has dementia, is to say that more than one area of his cognitive functioning has declined from what it used to be. Now, very often, one of those cognitive functions in a dementia is short-term memory. What did we have for dinner last night? But typically, there are other cognitive dimensions or thinking areas, like judgment. What's the right thing to do in a certain situation? It includes things like finding the right words. You go to the library of words in your mind, and you kind of get the right word off the shelf to use it, and that doesn't always work quite right when someone gets a dementia. So remember, dementia is a description. It's not a statement of how the brain got that way. Okay? So dementia, shoulder pain, and now we have to figure out what are the different things that cause shoulder pain? What are the different things that cause a dementia, if you will? So I'm going to break this down into what I call kind of the buckets. I like to think in buckets so I can categorize different entities. So we pause now for a word from our bucket sponsor. So here we are back with our high-tech, computer-generated, expensive graphics on Dr. Andrew Reeves' Neurology. This cost us a lot of money, let me tell you. Remember, dementia is this overarching kind of umbrella or this description of how the brain is functioning or maybe not functioning quite the way it used to. And this is not an exhaustive list of things that cause dementia, but this kind of buckets the main things that we think about and the main things that we need to test for when we can do tests. We can't test for everything. So I think about the buckets of the common causes of dementia. For example, the bucket here, this is what I think of as the group of things I call a chemical dementia. You can take medicines that mess up your memory and your thinking and your judgment. Okay, so there's a chemical that's messing up how the brain is working. Well, obviously you would evaluate for that and treat for that one way. They're not so common, but there are infectious causes of dementia. The brain infected with HIV, for example, and there's some other kinds of infections that can cause the memory and other thinking function to decline. So we screen for that. There are the group of things that I call the structural dementias, where the actual structure of the brain is being affected by something. This includes multiple strokes in different areas. That destroys some of the structure in certain areas. That includes too much water accumulating in the brain, we call hydrocephalus. That includes, not very commonly, but it includes various tumors that could grow slowly in the brain. This is typically the benign tumors that just grow slowly over the years and they affect multiple brain functions. So we often would do a scan, for example, to look for a structural cause. We'd often do blood testing for a chemical cause or to look at the medicines that somebody's taking. We would do testing for infections. There are other metabolic causes of dementia. There aren't a lot of them, but they do exist, and they're worth looking for. It's not very rare that as we get older, we lose the ability to absorb vitamin B12 very efficiently. rarely is it a problem that there's no B12 in the diet. The problem is, as we get older, we can't absorb it very well, and slowly we get low on vitamin B12, and then a dementia can creep in. Well, obviously you treat that very differently than some of these other things. For people who have intestinal problems that have been going on for a while, or have had weight loss surgery, copper deficiency can cause a dementia. People who don't have enough thyroid function can just slow down, and their thinking slows down, and they kind of become a little demented. Those are clearly treated very differently than these other things. And then there's this other bucket that I call the degenerative dementias. It's the dementias where the circuits are wearing out and they're degenerating, and there's many different flavors of this. This is realistically, this is the most common cause, and it's part of our job to try to figure out this, oh, excuse me, graphics. It's part of our job in neurology to figure out, well, have we tested for things in these other buckets? We do have some tests for some of these degenerative dementias, but they usually are fairly invasive, and we usually don't do them. Like, we don't want to go in and get a biopsy of the brain. And most of the reason is that we don't really have effective treatments for these. So if you can't really treat the disease, you would not want to do something that's very invasive, like surgery on the brain, to try to figure out if they have the disease. So let's pause now for another high-tech computer graphic on the degenerative dementias. Thanks for your patience. This is what I call alphabet soup. So these are the degenerative dementias. These are just some of the degenerative dementias. Alzheimer's disease, diffuse Lewy body disease, multiple systems atrophy, progressive supranuclear palsy, cortical basal ganglionic degeneration, blah, 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 blah. This is an alphabet soup of disorders that, frankly, we don't that well understand, and where the circuits are wearing out and degenerating in multiple brain regions, and that's why the brain isn't functioning the way it did before. Our ability to arrest these processes at this time, in 2016, is kind of zero. So we get into fistfights sometimes, at least some neurologists do, over, well, do I think this person has unusual Alzheimer's disease or diffuse Lewy body disease? And I say, well, that's interesting, but at the end of the day, it doesn't actually help you treat the patient particularly differently. The tools in the toolbox for treating all the degenerative dementias are really more or less the same. So we often are left not being 100% certain while somebody is alive which degenerative dementia they're suffering from. Most importantly, we've gone and tried to rule out the other treatable causes of dementia. Make sense? Great. Now, we do have a few medicines we use in neurology for the degenerative dementias. And what I'm going to talk about with our next awesome computer graphic is information that really is based on Alzheimer's disease, but we believe that it really pertains to the other degenerative dementias to a greater or lesser degree. And once again, we're going to have to get some buckets. So I'm going to draw a graph. And across the bottom, we're going to put time. And on the y-axis, I'm going to just put memory function. And at the top, we're going to have it be fairly happy. And at the bottom, the graph goes down to not so hot. Now I'm going to tell you about my aunt. My aunt developed Alzheimer's disease in her early to mid 50s. So she was cruising along, doing okay with good memory function, and then she developed Alzheimer's disease. Now let's just say that it started right here. Of course, you don't know the first day or the first week or even the first month because we all have good days, bad days, so it's really hard to know when things started. So she starts declining a little bit, and it takes a little while before people realize, hey, something's going wrong here. So take her to see the doctor. He says, well, we checked all these other things in the other buckets. We didn't find anything. We think you have a degenerative dementia and probably Alzheimer's disease. So if this is her natural, if you take 100 or 1,000 people like my aunt, and this is kind of going to be her natural course over the years, she's going to have a progressive decline. We'd like to do something to treat that, and we do have a couple of treatments. Now, here are our buckets. Now, one bucket has 3 drugs in it, and we'll just use some initials there. And the other bucket has Namenda or memantine in it. Now we often will use one medicine from each bucket. Of course, there's only one in that bucket. And what I'm going to tell you is really true of both buckets in their impact on the course of the disease. So my aunt gets started on the medicine, and here's on average what happens. So for a time, she declines or sort of stabilizes, or maybe doesn't decline as quickly as she would have. And then after a time, measured in months or a year or so, not 5 years, she begins to pick up the same speed as if she hadn't been on the medicine, but we've kind of moved the graph out a little bit, if you will. That's not terribly satisfying for the patient, the family, or Dr. Reeves, because we start somebody on one of these medicines, they come back 3 or 4, 6 months later, you know, how's Grandpa Leroy doing? Well, I don't know, I think he's a little bit worse. And we kind of say, yay, that's success. Well, that's as good as we have right now. The truth is we'll typically start one of these 3 medicines, and at some point later, maybe this one. Occasionally we do it the other way around. Doesn't really that much matter. You don't use all 3 of these medicines because these 3 medicines are more alike than they are different. It's kind of like, you know, you have penicillin, ampicillin, and amoxicillin. Yes, they're 3 different drugs, but they kind of really work the same way, and you would never take penicillin and amoxicillin at the same time. That doesn't really make any sense. So you use one of these 3 drugs, and often use the one drug from here, and you hope for this. Now you might think, and you would be very logical, you'd think, well, when my aunt gets out here, and it's pretty clear that her rate of progression has picked back up, well, it's time to stop the medicine. Actually, that turns out not to be a good idea. They did that experiment, and you tend to see this. They decline fairly quickly. In fact, it was even shown that even if you take them off for just a few weeks, and then you say, whoa, bad idea, let's put them back on, they don't actually get back to where they were. They have still lost a little bit of ground. So that has led to when you're on one of these medicines, you're on it for a good long time, maybe the rest of your life. Maybe not. Maybe when my aunt got out here, there was kind of, what's the point? Okay. But certainly, we're in the early and middle and even later part of the disease. When you're on these, if you can tolerate it, you generally need to stay on the medicine. So this has to do with progression of the disease. There's a whole host of other treatments, medications for the symptoms, you know, anxiety, depression, restlessness, lack of initiative, and we don't really have the time. This isn't really the place to go into this large array of medicines, which frankly are just as often used by psychiatrists or primary care providers than by neurologists to try to manage the symptoms. Now, I'm going to give a shameless plug. My shameless plug isn't actually shameless because it has nothing to do with me. There's a book we often recommend to family members, caregivers of someone who has dementia. The book's called The 36-Hour Day. And we're going to have our camera girl director, Alana, put it right here. Can you see that there? Right? Yeah, The 36-Hour Day. And there's a great number of resources available through the Alzheimer's Disease Foundation, associations of various kinds online. And it's really important to have some pretty good talks in the family when there's a dementia about what are we expecting for the future, how are we going to manage the decline. Because unfortunately with the degenerative dementias, at this point, decline is going to happen. Now obviously we hope it's pretty slow, and we hope it takes a lot of years, and we hope that that's not too bad and the person doesn't really suffer and the family doesn't suffer. But it's a good time to have talks about how are we going to manage this, and how are decisions going to be made. When do we stop driving? Who manages money? Who has a healthcare power of attorney? Who has a financial power of attorney? Who's keeping an eye on the person with the financial power of attorney? A whole lot of things have to be talked about. So, thanks for your attention and your time. I appreciate it. This was a really quick Cook's tour of dementia, covering that there are infectious and structural and metabolic disorders and various chemical disorders that can cause a dementia. Degenerative dementias, the most common Alzheimer's, yes, but there are others, are a big bucket. And that the term dementia is a description, it's not a statement of what's happening at the cellular level, and that there's a whole lot of stuff that goes with having a dementia. So, thanks for your attention. Have a good time. Bye. Oh, the glasses.
Okay. Yeah. So, these are the times when I actually want froyo, and this is when Dad will actually take me to froyo. So the times I want froyo is like all the way up here, which is mostly all the time. And it goes downhill from there. Like, it doesn't take me ever. It's on my graph.